Hi, I'm Milan Herceg. I'm one of the spine surgeons here at the Ohio Orthopedic Center. One of the unique things about our center is we have a very high number of fellowship-trained surgeons and conservative physiatrists. Many of these doctors have done training far beyond their medical school and residency training, and a fellowship is a certain specified time frame where you work specifically on your area of interest. For myself, I'm a spine surgeon, one of the two spine surgeons here at the center, and most of my focus during the day obviously is on adult spinal disorders or common pathologies of the spine. For us, that's oftentimes things such as back pain or sciatica as they're commonly called, and most of those things fortunately can be treated conservatively with physical therapy or perhaps an injection or even a short course of anti-inflammatory medication. Some of the common problems that we see, other than back pain or a lumbar sprain or strain, involve injuries to the lumbar or cervical spine. The base of the lumbar spine is the tailbone, which we see here commonly called the sacrum or more commonly referred to as the tailbone. There are usually 5 lumbar segments. These are called the vertebrae, and they're numbered, the 5th one being the lowest, 4, 3, 2, 1. Between each vertebra is a disc, and this disc serves as a shock absorber. It also allows a pivot point in the motion so that we're able to flex and extend around our spine. Here is that cushion or intervertebral disc. This illustrates a herniation of the disc, or what's commonly called a slip disc or a disc protrusion, which may pinch on a nerve root. Over the course of time, patients can have pain of the sciatic variety, which would be from a disc herniation pushing on a nerve as we see here. Other common ailments could be a degeneration of the disc where the shock absorber no longer works efficiently. The final thing can be arthritis of the joints in the back called the facet joints, and those little joints are kind of the knuckles of our spine. Those are the small joints in the back, and you can see you have one on the right and left side at each lumbar spine level. Some of the myths that were true of spine surgery in the past certainly are no longer true, and there's been a couple reasons for that. One is the MRI scan. The MRI scan allows us for a very precise diagnosis of the surgical problem. Historically, we would have sciatica or a problem with pain radiating down one of the legs. Oftentimes that was followed by a test that may or may not give good diagnostic value, and ultimately a diagnostic or an exploratory type surgery was done. Fortunately, exploratory surgeries aren't done in spinal surgery anymore. The MRI is one of the best advances that has helped us to really localize pathology from a diagnostic standpoint. Here we see a disc herniation between the 5th and 6th cervical vertebra pushing on the spinal canal. These are what's called the sagittal images, where you see the disc bulging into the canal, where the spinal cord is the gray structure and the white is the fluid around the spinal cord. These are axial cuts or cross-section cuts, which show the disc herniation as well. Here on this film we can see that the disc herniation is slightly to the left side, the spinal canal is here centrally, and the right side is more free. This patient had some left-sided arm pain that went down to the thumb region, and that would be very consistent with what we see here on the MRI scan. The advances of the MRI have helped us very much in diagnostic purposes, in that we're able to very clearly pinpoint where the pathology or the pressure is on the nerve. Obviously that lets us treat it much more efficiently and effectively. We're here at the Ohio Orthopedic Surgery Institute, and we're going to come inside and take a quick peek around. Oftentimes in the past people would have inpatient procedures or different things done that required prolonged hospital stays. However, as we discussed upstairs, with microscopic surgery and different and better diagnostic technologies, many of the things are able to be done on an outpatient basis. The nice thing about the center is that we're able to do a lot of the different procedures, both more conservative procedures as well as open surgical procedures. Here you see our injection suite, where we use what's called a fluoroscopy machine, which allows us to get an x-ray of the patient's spine as we're doing an injection. So we're able to place the needle exactly where we want it, and oftentimes we're able to place a contrast dye to make sure that the fluid or the injection material, often referred to generically as an epidural or a cortisone injection, can be placed in the right place. And then on this screen we're able to see the picture of where exactly the needle and the dye is, so that we know we can do an accurate injection, and certainly we are able to do that safely. Here at the center we do several thousand injections a year, so this gets a lot of use during the week. The most common diagnoses that would necessitate a procedure such as this would be lumbar spinal stenosis or herniated disc of the lumbar spine. Those patients often receive an epidural type of injection. There are other injections we do for facet problems or degenerative arthritis of the back called facet blocks, or even medial branch blocks and radiofrequency neurotomies. The typical course for a patient who would be receiving an epidural injection or a facet injection or these type of things would be that they would come in, essentially go through a quick registration process, and the procedure usually takes somewhere between 5 and 15 minutes depending on the type of procedure, and usually within 1/2 hour after the procedure the patient's able to go home. So these are all truly outpatient procedures, and often the patients are here much less than 2 hours. Oftentimes, when more conservative approaches such as epidurals or facet injections fail, patients do require open surgical procedures. Fortunately for us, we're able to do that oftentimes in an outpatient setting, which we're able to do here in our center. And this leads me to one of the favorite places that I have in this building, which is our surgical suites. Herniated discs that don't respond to physical therapy or epidurals or both, they often require a surgical procedure such as a microdiscectomy. That procedure has been very much perfected over the course of the last several years, and we're able to use the good diagnostic tools such as MRI to allow for a precise decompression. We know exactly where the disc herniation of the problem is, and it allows us to make a small incision, and using a microscope, we're able to remove that pressure on the nerve. Most common procedure that we do here from a spine standpoint is a microdiscectomy. We did 6 such procedures here today. Oftentimes these patients come in and it's a very similar process to the epidural. There's a short registration process. Patients have a procedure which usually lasts 20 to 30 minutes, and often for 30 to 45 minutes after the procedure they're able to go home. The post-op recovery from such a procedure often is quicker than most people would expect. For my discectomy patients, people are back to no restrictions in about 4 weeks. Oftentimes patients return to work the next week or take a week to 2 off of their normal occupation. As we discussed, most of the ailments that we'll see on a day-to-day basis can be treated conservatively on an outpatient basis. However, some patients do come to needing surgical intervention. Fortunately, some of those patients can be done on an outpatient basis, such as a microdiscectomy surgery or even some one-level fusion type procedures. Other procedures may require a short hospitalization, such as a fusion type operation, which may require a 2 to 3 day hospitalization. Lumbar fusions typically have had a very bad press as well. Fortunately, most of the fusions we're doing today are for very specified diagnoses and are very helpful in relieving patients' pain. Most surgical interventions fortunately don't take the hours that they did in the past. As part of our fellowship training, many of us focus on these procedures and do them routinely on a day-to-day basis. Most of our discectomy surgeries, for example, take 20 to 30 minutes, and most of our surgical fusion procedures take anywhere from an hour to an hour and a half. As a group of spine care physicians, our ultimate goal is to get people back to doing what they like to do. And we'd like to do the least amount of things to the patient to get that done. There are different choices for different people, but oftentimes surgery isn't the end of the world. It's far from it. We have many patients, some of the pictures here in this office, that share and illustrate some of those points. For example, over here we have one of our triathletes who did an Ironman triathlon just 2 to 3 months after a discectomy surgery. So oftentimes surgery isn't the end of the road, it's the start of a more exciting future.
For more information or to make an appointment, visit www.ohio-ortho.com or call us at 614-827-8700.